It's Dr. Centeno, and today we're going to talk about a number of different things, obviously, but we'll start with the topic of what to expect after a PICL procedure when used to treat craniocervical instability. And so, what I mean by that is really, obviously, this could be 3 or 4 months in total recovery before you get to a second procedure. But I'm really talking about the first few days. Uh, and what to expect during that time frame. And I think this is an important conversation to have because sometimes we have patients that really thread this needle well and sometimes not so well. So we try to put out as much information as we can. Now, we have written information, we've got an entire book about this procedure. And so I want to do a video as well so we can get this information out to as many patients as possible. So let me see if I can go ahead and share my screen here. And I'm going to go to this presentation first. Now, after I'm done with the presentation, obviously I'll take any questions about anything as I always do, including this topic or other topics. So it doesn't have to be what we're talking about here. But we'll start with this presentation. And that is, again, what to expect in the first few days after the PICL procedure when that's used to treat craniocervical instability. And then obviously just put your questions down and I'll get to them when I'm done with this. This should only take about 10 minutes or so. So like all procedures, the PICL procedure has a bell-shaped curve. So what that means is that the recovery for most patients is in here. So that's like 7 out of 10 patients have 3 to 7 days of increased symptoms. And then we've got people on the shorter end of that, another 15% or so, who just have 1 to 3 days of increased symptoms. And then we've got people who have no real increased symptoms at all. I talked to them after the procedure. They don't really have anything. 3 days out, they don't have much. So that's on the normal to good side. So as you can see, 7 out of 10 patients are falling in here. But we do have, obviously, the other side of that bell curve. And so another 15% of patients who might have a set of days of increased symptoms, weeks of increased symptoms, another 5% or so who might have 1 to 2 months of increased symptoms. So just realize that most patients are obviously, thankfully, in here. And then we've got another small chunk in here, and then an even smaller chunk who are out here. So just realize that that's the deal. Now, who are the people who are going to have the longer term recovery? Those tend to be people who are lower functioning, have more day-to-day symptoms, people who get flared up by a massage, for example, who might have central sensitization or a central nervous system that's extremely sensitive. Or, they may have a small amount of symptoms, but they live their life in an extremely rigid way to avoid those symptoms. And that's going to be a good chunk of our patients. But those are the people I think are more likely to have more symptoms over this first few days to few weeks. So what are the increased symptoms we're talking about? Now, most of these are going to be what I call index symptoms. Those are symptoms you already have. So if you've got dizziness or headaches or nausea or anything like that, those symptoms can go up during this time period before they come back down to what they normally are. And then we can also see patients who just have increased upper cervical symptoms because we're treating the upper cervical spine. So that might be headaches or dizziness. And those are specific upper cervical symptoms. So there's inflammation in the upper cervical spine. So those symptoms they may not have had before, but they may have for several days afterwards because of this, or it may follow that bell curve we just talked about. Usually the ones that tend to follow the bell curve are these, the index symptoms. And while these happen, they tend to be more short term. And because of this, it's really important that you have somebody traveling with you. And I think most of our patients respect this. Sometimes we see someone who can't do that, and we try to get them some help, meaning someone to stay with them that first night. But it'll really help you if you had someone traveling with you. For instance, to help you when you get up to go to the bathroom, because you can fall, right? If you've got dizziness related to the procedure, you might fall when getting up to go to the bathroom, especially at night or when it's darker. Someone who can help you get food, who can assist you if you're having other symptoms, make a phone call with you, text your doctor, all of that stuff. Someone who can act as your advocate is critical when you're getting a procedure like this. And then if you have dizziness or imbalance after the procedure, again, I just want to make sure that I drive this home, that you've got to have someone to assist you when you get up and move around, because you're at a greater fall risk during that time. So very, very critical that you have someone traveling with you and that you understand that that person needs to actively assist you until all of this calms down to what you're used to managing on a day-to-day basis. Now, nausea and vomiting can happen in about 1 in 5 patients, and sometimes that's just because of anesthesia. And regrettably, about 1 in 5 patients really don't like anesthesia, and they don't do well with it. Now, we can give anti-nausea, also known as antiemetics. That includes medications like Zofran, Compenzine, scopolamine patch, and we try to aggressively use that to bring that number down. But in some patients who don't have anesthesia problems, this could be provoked by the procedure itself. And it's usually short term, only 1 or 2 days. And in some patients, oral narcotics can cause this. So we may need to take them off of their oral narcotics because they feel nauseated by taking, for instance, Percocet that they were given for pain control, things like that. And it's because of this that we tend to see people back in the office the next day. And that's about 1 in 5, 1 in 4 patients, somewhere around there, that come in and take us up on that. Now, Colorado is at altitude, and that's where we are. So patients can get dehydrated if they're not drinking because they feel nauseated. And here, if you do that for any length of time, you're going to get dry. So again, about 1 in 5, 1 in 4 patients come in the next day for IV hydration. And almost everything can be handled in our office. So if the patient needs IV fluids, more medications for nausea, pain control, if we need to check their temperature and CBC for possible infection, additional procedures need to be done, etc. So just realize that we'd rather you call us first than head off to the ER, because when you get to the ER, they're generally not going to know what you had done and the expert care that might be involved in trying to see if there's a problem or not. They're going to just apply a one-size-fits-all to whatever you tell them, and it's going to be an expensive trip because obviously if you come back into us and we do these things, we're generally not going to charge you, or we may bill your insurance for the visit, but it's not going to be the same thing as going to the ER, which these days can get to be increasingly expensive. So your doctor is really just a phone call away. We take all our own call. We do that for a reason, because we don't get called all that often. And if you've ever tried to get in touch with me, unless I'm sleeping and didn't wake up, in which case, call me more than once. I'm pretty quick on getting back to patients. I do it all the time. Text works great. I get back to patients frequently. In fact, I was texting patients all this weekend while I was at a wedding, for example. So we'd rather you please call your doctor first if you're having anything that just doesn't seem right to you. And there's usually no reason to go to the ER. Now, if your doctor feels like you need to, he will tell you to go to the ER, and that can happen. But usually we can take care of it in the office. And because we can take care of this kind of stuff in the office, it's usually better to try to get to reach us before the office closes, right? So for instance, if you're having problems on Friday morning and by Friday noon, things don't seem right, don't wait till Friday at 7 o'clock p.m. to call. Call at noon on Friday so we can get you into the office and take a look at you. Or again, same thing after a procedure on Wednesday. The next morning, Thursday, just not feeling right, give us a call in the morning so we can work you in to be seen rather than waiting till later that night where the only option is, well, I can't see you right now, so you're going to have to go to the ER. So just try to plan that a little bit. And these are the biggest things we worry about, just so that you know. So obviously, fevers, chills, sweats, we're always concerned about infection. We haven't had infection related to PICL at this juncture, but it's always a theoretical possibility. Severe pain combined with a severe inability to think, much more than you're used to experiencing, because sometimes that happens in CCI patients. Leg swelling or shortness of breath or a DV, which would be a possible blood clot, and new onset symptoms that just don't resolve or seem to improve as the first few days go on. And don't worry if you need to postpone your flight. We're happy to see you back in the office if you postpone your flight. Obviously, these days it's a little easier to get out of flights, but if for some reason they're giving you a hard time, we'll give you a doctor's note, etc. And that's it. So let me stop the screen sharing and I will get to answering some questions here. A whole bunch of questions have come in. So let's start with some questions. Hi, Dr. Centeno, my friend had one cortisone injection for a bulging disc, then the fibrin disc seal procedure injection into the bulging disc. Her recent MRI shows arachnoiditis. Does Regenexx or other body procedures ever see arachnoiditis from PRP, VMC? No, Robin, I haven't seen any kind of arachnoiditis specifically after PRP, platelet lysate, or bone marrow concentrate. Now, the problem with cortisone injections, we do know in joints, for example, is they increase the infection rate in subsequent procedures or surgery if someone has gotten a cortisone injection or a high-dose corticosteroid injection. So it's possible that that could have caused that, or it's possible that the fibrin disc seal procedure caused the arachnoiditis itself. But I haven't seen a case of arachnoiditis with PRP, platelet lysate, or bone marrow concentrate to date. So that's something you'll definitely want to bring up with the folks that did the disc seal procedure. There may be something specific about the fibrin glue that was used that caused the arachnoiditis, but we generally don't see that. Sarah, I have internal jugular vein compression by C1 in both veins and get nausea and dizziness just by moving the neck. Why is that? You know, Sarah, if you go to, let's see, we got a whole blog on that. So I'm going to try to pull that up here. Let's see, let me find that first. Okay, so let me share that. Okay, so this is the blog I'm talking about. So if you go to regenexx.com with 2 X's, as you can see here, and you type in really just the word jugular under the search, you'll see that a number of different blogs come up, including this one. And it talks about intracranial hypertension. It talks about how that happens due to the transverse process of C1. It talks about different symptoms that can occur, why that happens when someone moves or turns their head. The more common symptoms of internal jugular vein compression and how it's diagnosed, and how we need to be a little careful, because an awful lot of patients who get diagnosed with this need to understand what I have right here. And that is that if we take people who do not have any symptoms of internal jugular vein compression, about a third of people walking around out there with no symptoms have moderate jugular vein stenosis. And severe stenosis was seen in about 1 in 5 or 1 in 4 people. Severe bilateral stenosis was seen in 1 in 10. So we need to be careful. Just because someone found internal jugular vein compression on a CT venogram doesn't mean that that's what's causing your symptoms. So it's very important to understand, and that may be frustrating to patients to hear, but it's extremely important to comprehend. Manuela, Trican, when should we start moving more after PICL or even exercise? So Manuela, that's going to be related to very much activity as tolerated. So activity as tolerated means is if you have increased symptoms due to the procedure, you want to back off from what you're doing. But if you're back to what you normally have, you can do what you normally do. So that's what activity as tolerated means. And as far as exercises to strengthen your neck, you want to definitely clear that with your treating physician before you go there. Phil, I had prolotherapy with dextrose, or I heard prolotherapy with dextrose causes scarring in the ligaments as part of strengthening. Is PRP cause scarring or just healing? Yeah, so Phil, let me give you a demonstration visually of what we're talking about here. Prolotherapy doesn't cause scarring, certainly not if you're just using hypertonic dextrose. So when you're laying down new tissue, let's represent the new tissue by some lines here. So let me go ahead and switch the share here. So when you're laying down new tissue, that new tissue, when it's initially laid down, gets laid down in a disorganized fashion. And so that means that the collagen fibers kind of go every which way. Now, that's kind of the definition of scarring, but not really when it happens acutely, like it does in these orthobiologic treatments. So the tissue gets laid down randomly. Now, once that gets loaded over time, the tissue realigns, or the collagen fibers realign. And as they realign, that strengthens the ligament or the tendon or whatever it is we're treating. So now all of these collagen fibers are aligning over time as that area gets loaded. And we went from something that looked like scar tissue now to something where all the fibers are going the same direction. So prolotherapy doesn't cause scarring. I think that's a wise tale that you heard on social media. In fact, the research on prolotherapy, when they've looked at electron microscopy, shows normal healthy tissue that's thicker. But I think what they may be confusing is that all new tissue is really disorganized until loading organizes those collagen fibers. Robin, looking forward to next treatment with you for your headache workup. If physical palpations show multiple hydros warranted, how many hydros can you do at once? So if we were looking at multiple nerves being involved, let's say for headaches for the occipital nerves, how many as would be necessary. So there's no real limit to the number that we can treat at once. Manuela, how important is atlas orthogonal? Yeah, we're big believers in atlas orthogonal or NUCA chiropractic after this procedure. So, but we also want to make sure that that person has an existing relationship and is being treated successfully by somebody before they do the procedure, and then they would continue with that after the procedure. So that's definitely something just to realize, to establish that relationship and get the vectors down before the procedure, and then realize we've seen vectors change as a result of the procedure. So that's something that may need to be looked at if you have an existing relationship with an AO or NUCA chiropractor. Submitted advance. My CCI was caused by an automobile accident a little more than a year ago. Would I likely need fewer procedures or a quick recovery than someone who had these issues for a very long time? Yeah, Harry, that's my overall thought, is that it would be more common for you to need fewer treatments. But a lot of that also has to do with how severe the injury is to begin with. So that's something that we'd have to take a look at as well. Donna, I'll be seeing this week on Wednesday and Thursday. Hey, Donna, look forward to seeing you in the clinic. Yamas, in my case, I took medicines. I vomited 5 times. Last 2 procedures didn't cause that. I think what you're saying, Yamas, is that probably the Percocet or one of the oral narcotics caused some nausea, and that's not uncommon. So what we'll try to do there with a patient is to go ahead and give them a different type of narcotic or a different type of drug to see if we can get rid of that. Because as I said, oral pain medications can sometimes do that to patients, and that's a good one to avoid if we can. Thanks, Tom. These pictures are deadbeat. I'll be 100 times better. Those PIs, I don't know what deadbeat means, but anyway, CBD, yeah, if you use CBD or THC, just realize, it has some negative impacts here. One negative impact is that it's going to be much harder to put you asleep. That's now well known in the anesthesia literature this last year or two. So what that means practically is that you might break through the anesthesia more often. So you might be much harder to keep asleep during the procedure. So just realize that there is no free lunch, meaning these are drugs. CBD and THC are drugs, and they will have an impact on our ability to put you asleep. Now, sometimes that's something we don't notice. Other times it is very, very noticeable, meaning we're using 2, 3, 5 times as much medications to get someone to sleep. So you can certainly do that, but realize that it does not have zero effects, that these are drugs, and those drugs have impacts on other things. Via, can you have jugular vein or jugular compression without tinnitus but other symptoms? Sure. So in fact, let me get back to that share here, guys. Hold on a second here. So if we go back to those symptoms, that's a word cloud. So this is actually based on a paper on internal jugular vein compression. And the size of the word here is the more common symptom. So insomnia was number 1. Obviously, there's 1,000 things that cause insomnia, so that's not real specific. Head noises would be more specific, and that was number 2. About that same number of patients reporting would be tinnitus. So tinnitus and head noises, I think, would be more specific to jugular vein compression. Then hearing impairment, and then headache and neck pain were actually less commonly reported. So not everyone reports all of these things. These are just the size of the word here is the frequency at which patients with this diagnosis reported these things. So that means there were some patients that reported tinnitus, some patients that didn't, some patients that just had hearing impairment, some patients that just had headache, etc. Rachel, I feel so fortunate. I was in pain for a few days, but had 0 exacerbation with CCI symptoms from PICL. Yeah, Rachel, and that's actually most people. As I said there with that bell curve, most people are in that realm. but it does happen where you see patients that that get increased index symptoms. So that's great that you didn't. Yamas, a good precise AO adjustment can cause miracles right after the procedures. Yeah, so Yamas, if someone already has a relationship with an AO chiropractor, then we definitely want them to get an AO adjustment right after. And we also have seen that improve a lot of patients. Cayenne, why does the PICL cost so much money? If you have proper instability issues, you won't be able to work. And how do you pay for the procedure then? What route can you go down? Or CN? Yeah, PICL is a fraction of what a fusion would cost. I mean, the average fusion these days is running about 100K. Sometimes less. I think the lowest fusion out-of-pocket costs I've seen are in the 60 range. So PICL is a fraction of that. As far as if you've got craniocervical instability, then you can also try to see if you can qualify into the randomized controlled trial we have going that doesn't cost anything. So you may want to reach out to Aaron Dodson if you haven't. And I'll put Aaron's email down here. Putting that in the comments there. But she runs all of our clinical studies, so she could see if you qualify for something like that. Regenix submitted advance by Maria. Would I need a medical visa to come to you for treatment? Yeah, Maria, I don't know where you're coming from, but yeah, that might be necessary depending on which country you're coming from. Usually the visas are needed more from countries like China, etc. Haven't seen them be needed from Latin American countries, but it's possible if it's something like Venezuela. Phil, thanks for the clarification. I also heard that one PRP procedure has the same benefit as 5 prolotherapy treatments. I don't know if that's true. How I quote this based on my clinical experience is a good way to look at this might be something like SI joint instability in the low back, especially in women who tend to require a lot of prolotherapy treatments. So the average number of prolotherapy treatments in women who have SI joint instability would be 4 to 8. And if you do that with PRP, in my experience, you can do it in half that, 2 to 4. And if you use bone marrow concentrate, it's 1 to 2. So you can move things more quickly along by changing what you're injecting. Now that's not 5x, right? That's kind of like going in half number of treatments. So 4 to 8 of prolotherapy would go to 2 to 4 of PRP or 1 to 2 of bone marrow concentrates. That gives you, I think, a better way to look at that. But it's not 5 to 1 that I've ever seen, at least. Shanza, higher Centeno, what's the minimum overhang that PICL being recommended for? Every case is different. Roughly how many PICLs can we expect? Get an average to maximize healing and stability. Yeah, Shanze, so the minimum overhang we look at is 2 to 3 millimeters based on the Katz et al. Paper of normals. And then what I tell patients is about 1 in 5 of our patients get a single PICL and they don't get any more. So that's 20%. The other 80% are getting somewhere between 2 to 4 procedures to get where they want to be. Sarah, if you have instability C0, C2, it would be more convenient doing PRP in C0, C1, and C1, C2. You know, Sarah, it just depends on what's causing your instability in that area. So for instance, is it being caused by the internal ligaments, which can't be reached by doing PRP in C0, C1, and C1, C2 from the back? Or is it being caused by the easy to reach ligaments in the back, like supraspinous, interspinous ligaments? I would say that for most of our patients who we diagnose, again, having CCI, only about 20% of those or so are falling out of the protocol at this kind of posterior injection. About 80% are still needing to go forward with the PICL procedure. And in fact, for a very long time, the first couple of years, we wouldn't even allow patients to have access to PICL unless they did these posterior C1, C2, and C0, C1 injections using PRP. The problem was not that many people were avoiding PICL, so we changed that. Shanze, if an area feels very loose, almost like jelly, when there's, or where there's no stiffness and muscle activation, it feels unstable, can PRP be done there? Some pain management doctors indicate dextrose for looser areas and PRP for very tight ones. What are your thoughts? Just realize, Shanze, you can't really treat this area in a pain management clinic because it's an extremely specialized area. As far as injecting like the upper cervical facet joints, I think we've talked about that many, many times on this channel and during this show. Basically, you know, if we take 1,000 interventional pain management doctors and ask them how many times they've injected C0, C1 facet joint, we'll probably get out of that 1,000 doctors, they're all highly trained, but probably 5 that have done it more than 100 times in their career, and probably only 10 that have done it more than a dozen or 2 dozen times. So as you might imagine, if you do something 1 to 2 dozen times, let's say you're learning to play guitar, right? You try to do it the first 2 dozen times, you're pretty bad. After 100 times, you're reasonable, but you're certainly no guitar virtuoso. After 1,000 times you play the guitar, you're pretty good at it. You may not be about to go on stage as a rock star, but you are good. You sound good. And it's the same thing with these procedures. You can't get good at these procedures by just doing this 10 times, 20 times. You have to do it hundreds or thousands of times to be an expert in this area. And regrettably, there's just not enough doctors out there that can do this stuff in this spot. Brett, I was told THC or CBD can have a negative effect on ligament repair. True. I don't think anyone knows that one yet, Brett. It's possible. There's at least 1 or 2 studies we found that show that THC tended to push bone marrow stem cells towards turning into adipose tissue rather than staying differentiated or undifferentiated. So I certainly would be a little careful there. Now, listen, if at the end of the day, however, that helps you manage your pain and keeps you off high-dose narcotics, great. But just realize that just like if you were on high-dose narcotics, the amount of anesthesia it will take to put you asleep is going to be dramatically higher because you're on THC and CBD. So there is no free lunch, meaning there's nothing that can take away your pain that won't impact the amount of anesthesia you'll require to stay asleep. It all increases that amount of anesthesia, and that just increases risk for the patient because the more medication we use, the more likely it is the patient can crash during the procedure. So just realize, again, that those can be very helpful things. I live in Colorado, Rocky Mountain High. This is where the recreational marijuana stuff in the U.S. started, meaning we've had recreational marijuana now for a decade. And so a lot of my patients, they sell CBD in 7-Eleven here. So we see a lot of this, and we've figured out over time, what the good parts are and the bad parts. It's not all good. It's not all bad. Shanze, is there a TMJ specialist you recommend who can help the bite alignment and jaw support while pursuing PICL regenerative work for both cervical and jaw? Yeah, Shanze, usually what we're dealing with there is treating the TMJ at the same time we're treating the neck. And if you want to read about that one, if you go to the blog here and you were to type in I'm going to guess that I can find it with that, but we will see. No. Let's go CCI. Still not. Let's try one more time. I just remember what this one was about, so I'm trying to find it based on that. Here it is. Yeah, so this blog, and here's the address way up here, but basically TMJ stem cell therapy, Valerie's story talks about in detail, what happened with this patient with TMJ. So you want to read that because we treated her upper neck at the same time that we treated her CCI. And this is Aaron's, just so you have it. If you're interested in pursuing or seeing if you're a candidate for a randomized controlled trial, which is no charge, then this is who you want to reach out to. She can see if you meet the minimum criteria for that. Rachel, Dr. Centeno, I'm 7 months out from my first PICL. I'm not seeing any significant improvements. It's still possible to see results. Generally not, Rachel. So then we get into the next step. So the next step would be if you had significant overhang on DMX, then we can go ahead and try to see if you had any interval improvement. And if you had interval improvement and no symptomatic improvement, then we would probably move on to number 2. Now, if there isn't something easy for us to track, like overhang on DMX, then we got to make a judgment call whether or not you want to move on with the second procedure or not. That'll depend on what you had done and whether or not, for instance, in the first procedure we did above and below, meaning if not, then we would need to do above and below in a second procedure, etc. But that's a good one, and usually we can have a tiebreaker, so to speak, if we have patients who have done reasonably well in DMX, meaning we reduce the overhang, which is pretty common, but aren't yet having symptomatic relief. Sure, CM, thank you. Via, is there an important neurovascular bundle between C1 and the styloid that might get compressed too when IGV is compressed? So yeah, there's a bunch of stuff in there. You've got the internal carotid artery, you've got the 9th cranial nerve, you've got the vagus nerve. So other things outside of the internal jugular vein that can also get compressed. And so symptoms there for vagus might be POTS-like symptoms, might be GI symptoms, or for example, for 9th cranial nerve, might be pain in the back of the throat. So those are some common other things that you tend to see. Sarah, what else can cause, I think you probably mean some variation of ICH in the brain, cervical area besides IJV compression. Yeah, I mean, the first question I would have, Sarah, is how was that diagnosis made? Meaning just increased opening pressure on lumbar puncture won't get you there. You would have to do specific monitoring in the brain in order to make that diagnosis. So that's the first question, meaning that someone may have told you that you think that you have that based on your symptoms, but really don't know that that's what's causing your symptoms. So I think I need a little bit more information there about how that diagnosis was arrived at. Manuela, what is PICL improvement percentage for large overhang? I have 6.9 and 7.8. Emanuela, those patients do very, very well. A lot of that would depend on why you have such large overhang. But in general, I think we're seeing about 7 out of 10 patients right now that get good relief or improvement in symptoms with overhangs in that range. Now, let's separate 2 different patient populations out there. Let's say one patient population that's had that for 20 years is probably going to do different than a patient that has that based on a car crash that happened 2 years ago. So just to give you some info there. Okay, I think I got through all the questions. If there's other questions, this would be a good time to put those in there. Manuel again here. My case is trauma 7 months ago from one chiropractic adjustment. Yeah, Manuela, so the next question I would have would be, do you have a history of EDS? Because we wouldn't expect to see a really, really large overhang like that on both sides after a single chiropractic adjustment, or were there other things going on? Now, we have certainly seen craniocervical instability caused by some very aggressive chiropractic adjustments, and I know there's some stuff out there. So you just said no EDS. Yeah, so traumatic CCI then, that would be kind of right in our bailiwick, so to speak, for this procedure. Other questions, guys, that I can answer? Okay, I'm going to start wrapping this up then for the day. So today's topic was on what to expect for the first couple days after a PICL procedure. And if you go back in the video, you can see what all of that is. Two more questions just popped up. Justin, for patients with relatively low numbers, 4 millimeter, do you expect fewer treatments to be necessary even if the injury is 19 years old? Yeah, Justin, what I don't know is the 19 years old part. But certainly if patients have lower overhang numbers, yes, I think we would expect fewer treatments. Sian, does the jugular vein compression from styloids need fixing prior to PICL? Usually not, simply because number one, jugular vein compression is common in normal patients without any problems. So that's the first thing to realize, meaning that just because we saw jugular vein compression from the styloids doesn't mean it's causing your symptoms, meaning that the research shows that if we just take 100 people off the street, in this case, who had other problems in their neck that needed to be imaged, that we would see internal jugular vein compression about 1 in 4, and those patients have no symptoms. So we have to be very, very careful to tie internal jugular vein compression, as we see on an image, to symptoms. And then as far as the styloids are concerned, if you have CCI, that's just, you may want to actually go back and read that blog. So why don't you do that? Because I think that's going to answer all your questions. So this blog here would be the one you'd want to read. So what is intracranial hypertension? What does it have to do with the neck? And that goes through lots of different things, including how the transverse process there can put pressure on the internal jugular vein. And if you look at these diagrams here, you've got the transverse process of C1, the IJV there, and then the styloid. So if you've got instability at all, that's what's putting the pressure on the internal jugular vein. So you'd want to fix the instability before you did decompression. There's another reason you'd want to do that, because internal jugular vein decompression is much, much more invasive than this type of injection procedure. So you always do the least invasive thing that's the most likely to help. You never jump over to a more invasive thing unless there's some really, really great reason to do that. Sharon, I find it not very clear what you can't do after PICL. Is actually a good idea to do a full range of motion even if you're able to do this part of PICL without any problem. Yeah, Sharon, so the guide there is all about symptoms. So if you have the symptoms that go back to what you normally have, doing full range of motion with your neck is not a problem after PICL. Betsy, did PICL 2 months ago and did all the facet joints in my neck with stem cells. One with a crazy pain, the back of the neck subside. It pulls on my neck. Betsy, you may want to reach out to the doctor that did that procedure. We generally don't use we generally don't inject all the facets in the neck with stem cells. So I'm not quite sure why that was done, but I would reach out to that doctor because I don't have an answer for that one on you or for you. Phil, mainstream medicine is very dismissive of CCI, which needs to change. Have we got some bulletproof medical papers, clinical trials that prove diagnosis and treatment methods for CCI work? Yeah, Phil, there's not on the surgical side for sure, and not yet on the interventional side. So that's going to be a while before that happens on the interventional side. On the surgical side, you have to ask the surgeons about that because they certainly haven't done randomized controlled trials at all, zero to date in this area. Sharon, intracranial hypertension or IJV compression, are we talking about high venous pressure, ICSF pressure, or is there no difference? As far as measuring those kinds of pressures, you would need to have a catheter-based system where you went up to that area and actually measured those pressures. There's no way to measure those pressures in any other way. So what I mean is that that's not opening pressure on a lumbar puncture, because that doesn't really tell you what we're talking about here. You would have to go take a catheter into the vein or a catheter into the cerebrospinal fluid area in order to measure those specific pressures. So there's no other way to get those pressures from any imaging or anything like that. So if we're talking about pressures at those levels, that's how they would have to be measured, which is a pretty invasive thing to do. Cian, can lower instability cause higher instability? Not so much cause, but we definitely see lower cervical instability in patients that have upper cervical instability as well. So usually it would be whatever caused the upper cervical instability is also causing the lower instability type of thing. I think that's my last question here. Any other questions I can answer? Okay, guys, well, I'm going to start wrapping this up because I do have a hard stop at 2 o'clock my time. So again, let's see here. Sharon may ask, do you see more CCI patients who are able to do full range of motion without getting symptomatic? No, most CCI patients can't do full range of motion without getting symptomatic in general. So that's generally one of the things that tends to nail the diagnosis, if you will, of CCI, is that cervical motion tends to make them very symptomatic. Now, sometimes they can use a collar and that dramatically helps. Sometimes collars tend to put their neck in the wrong position. It doesn't help. So it's usually got to be a very specific collar that's unique to them. Okay, guys. Well, thanks so much for watching today. I won't be here this Friday because my daughter's graduating college. And so I've got to go do all that stuff. So that'll be exciting. And I should be here this coming Monday, though, a week from today. And if I didn't get to your question, just Carol will go ahead and try to copy and paste that into the next time we do this. So thank you so much and have a great day.